As we introduced earlier, we have Jan from SouthernCare Hospice joining us today. She's going to be helping us learn some topics about what is hospice and what it is not, and when and how to refer clients and common caregiver challenges and how to respond. So I'm going to give her the floor, and we're going to give her a very warm welcome, and then we'll get started.
So I am what my title is Hospice Care Consultant. So I'm also an LPN, but interestingly, I started off as a nurse's aide. I volunteered in high school at a nursing home back in the day before liability. I would go and feed people. Now we can't let just anyone feed somebody because they're going to choke, right? So I started off doing that, and I realized that I just had the heart for caring for other people. Obviously, all of you do as well, because you're here in this profession. It's nice to see the men in the room. Thank you for stepping up, because there are those people who don't want a living. And if you look around, the majority of us are women in healthcare. So I give props to the guys. Thank you for doing that. Then after I got out of high school, I went to Kent State to go into the nursing program and quit like a dummy to get married. And had 4 kids, one right after another. And so y'all know what happens when you have kids. Your kids come first, and then you don't go back to school. And I thought, well, I'll always go back. I'll go back eventually. So I worked as a nurse's aide in the hospital, and I worked at a nursing home, and I cared for some other people private duty. So when I stand up here and say to you guys, I know what it's like to be in the trenches, I really do. And I think that there are no harder individuals than the people in this room caring for other people. And it is such an honor and to go to people's homes. It's very intimate. You watch TV, you listen on the news. The world's not a great place right now, and things happen. And just to be able to go into their home and provide that care is just really special. So I thank you all for what you do. I've been there 3.5 years. Here's my disclaimer. This PowerPoint is my science project that I waited to do until the night before it was due. No, really, this is what they put out. You're going to see on the slides, a lot of it's going to say the patient. I understand you call your clients. You don't particularly call them patients. So just know that it's kind of interchangeable, and I didn't say it. It's not on here to slight you in any way. It's just that's kind of what they have up there. Nobody likes to have somebody stand up here and talk to them either. So I'm going to you're going to see some of it on here and some of it I'm going to kind of ad-lib. But the hospice philosophy for SouthernCare is it's care that's focused on providing palliative care to patients with life-limiting illness, focusing on palliating the patient's pain or other symptoms, and attending to their family and loved ones' emotional, spiritual needs, and providing support for their caregivers. So one of the things with my job is when I go out, and I am usually the first person to get the referral, and then I'll go out and meet with the family or the patient. So how many people, and be honest, by a show of hands, how many people, when they hear hospice, they think, death? Next to. Yes, everyone thinks that. Everyone thinks that. So as recently as 5 years ago, because that's how it was. When hospice first was introduced into, society, it was set up by some nuns who were just caring for people at the end of life. House of Loretto, I had a little struggle with them because that's their calling, and they go all the way back. This is a Catholic, most of you know that place, Catholic nursing home, assisted living. I don't know that they have a whole lot of what we call them walkie-talkies. I'm sure you guys do too. A lot of people that are independent, but they didn't want to allow hospice in there because that was their calling, their mission. They wanted to take care of those people. So they haven't really, it moves very slowly in the Catholic church there with changes. So they haven't really been a whole lot open to hospice because they're still living in that they have to be dying and they're not going to live very long. And to this day, a lot of people still wait until 3 to 5 days before they pass to get on hospice services because no one wants to admit that we all have an expiration date. It's just not stamped on us. So we don't know when it's going to happen. So we really truly have to live each day like it's our last. And I know that sounds a little cliche-ish, but you just never know. And so what we try to do with hospice now is make every day the best day, because none of us know. It could happen, it could happen to anyone at any time. And we all pretty much are aware of that working in the medical field. So what hospice looks at now is more earlier intervention. You may have heard of former President Jimmy Carter had been on hospice for 2 years. 2 years. And then he passed away. So he truly lived on hospice. So we all have a baseline, and when we're young, our baseline's up here. Think about when you were young, you got sick, that you had something going on the next day or later that evening. It's like, I bounced down, but I'm right back up here. As we get older, our baseline gets slower and slower, lower to the ground. And we add on what we call comorbidities or other disease processes on top of whatever's happening. And our baseline it gets lower and lower. So every time they have an exacerbation of a disease process, it knocks them down and they never quite get back up to baseline. So hospice services can become involved earlier in the process and help them live what time they have left better by providing more intense care. So and they also can graduate. Did you guys know you can graduate off of hospice? You can be doing so well that you no longer qualify for SOP services. And that's truly devastating to families if they're not prepared for it. Because as we get into the slide, I'll talk about some other things that we do. And then just as you guys know, you are the eyes and the ears and the heart and the soul of this company. I'm sorry, they are. sorry, they are. And I know you guys know that, but you're also the heart, the soul to that patient's family sometimes. They are going to tell you things that they may not tell the doctor, they may not tell their other family members, they may not tell anyone, but you are intimately involved in that person and they trust you. And so that goes a long way with helping them have better quality of life. So our mission is to provide compassionate care and extraordinary service to patients and families that we serve. And so the next one, what is hospice? And it's a type of palliative care. So you guys probably, or maybe you know, maybe you don't, you're wondering what's palliative, what's hospice, what's the difference? Is anybody wondering that, or does everybody know? Okay, so hospice is considered the model for quality, compassionate care for people facing a life-limited illness, and it's about specific timing and purpose. So just let that resonate with you, and it'll come together. So we provide expert medical care, pain management, emotional, spiritual support, expressly tailored to the patient's needs and wishes. So all hospices follow the same guidelines and should be providing the same type of care. But not all hospices function the same way. They have the Medicare rules that they have to follow, but some offer different services than others, but typically everyone provides end-of-life care. Hi, come on in. And we're also there not only for the patient, but to provide support for the family. We focus on quality of life, comfort care, rather than curative care. Palliative care is for people of any age or stage of serious illness during curative treatment. It focuses on improving the quality of life, seeking a curative outcome, and it's often covered by regular insurance. So you may have a patient that has cancer, for instance, and they want to get chemo and radiation, and maybe even surgery, and they want to go on hospice care. Well, they can't be on hospice care and seek curative treatment. But palliative care, they can be on palliative care to help manage their symptoms, pain management, while they are getting the curative treatment. So a lot of times you might hear if somebody has cancer, they're going through chemo treatments, or they're getting radiation, but they're also on palliative care services. That means that There's palliative care companies, and we have a sister company that does it. We only do hospice. But what that means is they're going to the home and they're providing that additional care and support through palliative services. It's not as intense as hospice. It can be covered by regular insurance, as well as people can private pay for it. So I hate graphs, but this is on here just to show you basically that hospice admissions are on the rise, and these are eligible lives, and just, these are always not accurate for like today, but they started in 2020 looking at that, and so we're right here, and as you can see, it's just gonna go up. It's just gonna go up, and this is the hospice diagnosis market. So who knows what the top diagnosis for hospice services is? Just take a guess. No? Dementia, which plays right into this. So dementia / Alzheimer's / other cognitive impairments is a big bucket of diagnoses that patients can have for a very, very long time. It's not unusual for someone to suffer anywhere from 15 to 25 years up with dementia. It just progressively gets worse. So to be on and that is our number one admitting diagnosis is dementia, because it affects all these things that you guys saw on play right here. Can you imagine the people, and I'm sure you take care of them, that live on their own and they have to function in their own home setting? If you guys weren't there, what would happen to them? There's millions of people out there like that don't have the support from a service such as yours. And you add on an illness, and I did hear somebody say, well, that wire is supposed to be your oxygen tubing. You add on that, you add on the 6 green ones, which that might be a pill, particularly that they have to take that certain pill every day. But in that bowl is a lot of other colors too that they aren't able to navigate. So basically, it says by 2060, which, that's way down the road, the U.S. age population, 65 and older, is expected to reach 95 million lives. If you live that long, right? That's a lot of people. So the top 3 diagnoses in the U.S. as of 2021 is dementia, Alzheimer's number 1, cardiac issues is number 2, and cancer is the 3rd. So everyone thinks hospice cancer. It's not really that way. We also treat respiratory as well. Today at SouthernCare, we continue to see dementia as our number 1 diagnosis. And the patient has to have end-stage dementia. So there are different scores that we calculate people by. They have to need complete assistance with all their ADLs, eating, bathing, toileting, all those things. They have to be unable to carry on a conversation. There are some people that, and this is the hardest one, I think, for patients and their families, because they don't only lose that person on diagnosis, they lose them every day, sometimes several times a day. Because I bet you every one of you can raise your hand at the time the family member has said, well, they really had a good day today, they knew who I was. Or they were able to get their cereal on their own, and they were able to do something, but 10 minutes later, they don't know who they are. And it's just really, really sad. And those families need a lot of support. So you might have a patient that, they might have a little bit of confusion. They might say, oh, it's June. Well, it's almost August. That's not such a big deal. But where they don't know who they are, where they are, what they're doing, and aren't able to share or express their feelings, then they're starting on the range where hospice could help them out. They will stop eating, they will stop drinking, they will stop ambulating, they will stop doing all those things. And at that point, that's when hospice, we talked about early intervention. We also can't get involved too soon, because then what happens is that graduation period, and that removes a lot of support from the families, and it's devastating to them. So we always try to have services set up. It might be working with somebody like you guys. We do have times where a family, they're on hospice. When they're on hospice, they see a registered nurse case manager 2 times a week. I was only thinking about like, this is 5 days a week, this is the weekend. They might see a nurse Monday and Wednesday. We're gonna send the aide Tuesday and Thursday. And then on the 5th day is the other services, which could be the chaplain, the social worker, or a volunteer. So somebody's essentially seeing patients 5 days a week. We have the weekend for if they're needed. So when I talk about all hospices should be providing the same care, but it's not cookie cutter. It's all tailored to what the needs are. And I know you're probably sitting there going, okay, you send an aide, you do all this, where do we fit in? And that's on the further slide too. There are times where we reach out to our care partners because you might have a husband taking care of a wife and it's just too much. And what we provide is not enough. He might need chunks of time to where he's able to get out of the house, maybe go pay bills and do that type of thing. Or maybe we have people that their spouse still works and they need somebody to come in and services like you guys would be somebody that I would reach out to and say, hey, I have this person, I would call them client. I have this patient client that needs some additional help. Would you guys be able to service them for some additional hours? And that's something that we would, that's how you would get involved. Let's see. I think I missed this, what is hospice first though. What it isn't, I did miss that because it didn't print that slide. We don't provide 24/7 in-home care. A lot of people think we're gonna get hospice involved and they're gonna ride in on their Porsche, they're gonna take care of everything. We don't, we just do visits, like we do those 5 visits a week minimum, but we're only there max an hour and a half. And that's if the patient is unstable. Usually our visits are anywhere from half hour to an hour. So that frees up a lot of time for extra services to be wrapped around those families. We don't replace caregivers. No, if we go into a home such as your patients and you guys are already working in there, we're not in there to take that patient away from you. We're there to say, how can we help? How can we come together and be good care partners together and keep that sense of stability that they already have established with all of you, and let's make this person, the rest of this person's life, the best of their life together, is what we're looking to do. We provide support, but we don't take over all the tasks. They still need help to move safely, to be safe, to assist with hygiene, other foods and fluids, also to give medications. Hospice doesn't provide aggressive treatment or treatment like chemo or radiation. The focus for hospice is comfort, pain management, and symptom relief. So we also don't force medications. So if somebody is like, I'm sure you guys are there sometimes and you say, here's your breakfast, here's your pills, and they're like, no, I don't want them today. Well, there's ways around that. You could say, okay, why don't you eat first, although they should probably take the pills first. Sometimes you just you slide it in and they don't really realize that you're doing it, but we won't stand over somebody and say, you have to take this pill. We believe patients have rights, which you guys do as well. And especially with hospice, a lot of times it's not gonna matter whether they take those medicines or not. If they miss it one day, you gotta kind of pick your battles, and it's all about comfort and what the patient wants. Hospice will never force or pressure someone to take or do what they don't want to do. Hospice doesn't make end-of-life decisions for the patient or the family. There's nothing we do that speeds up this process, even with medication, and there's nothing we do that slows it down. Only God knows where we're going, or some of you don't, are non-believers, or maybe your higher power, whatever. Nobody knows. Nobody, like I said about the expiration dates, they're not written, nor is our time when we have to go. We do provide information, options, and support. We don't tell them when to stop eating food or fluids. We don't make any legal decisions. The patient, the family, and the medical team make the choices together, and sometimes it will be with your input. If we're seeing somebody and we notice that there's a decline in their ability to eat or pocket food, and you say, the last couple of days we've done here, she's just not eating. So then we're gonna have a conversation of how can we help? how can we do something different and continue to provide nutrition and substance so the patient doesn't become weaker, or is this actually, are we seeing a decline? So we'll have to have it come together so that we're all on the same page. Hospice does not transport patients, so we do not pay, that benefit is not paid for. Like we don't ship them to the doctor's office, we don't pay for ER visits, we don't pay for them to go shopping, to use private vehicles. That's all on them. Hospice doesn't pay for room and board, and this is important, and not a lot of people know this. So hospice is provided for wherever the patient calls home. It could be over at the senior building over here, could be in somebody's house, could be in a nursing home, could be in a hospital, independent, AL. We do not pay the housing fees. Like we don't cover, it doesn't cover for their rent, doesn't cover for their room and board when they're in a nursing home. We do have to have a contract with nursing homes, and it's a big, long legal thing, and it's really kind of like the rules of engagement, what we'll pay, what they can expect, and what we expect for them to be a good partner. And sometimes when people are in a nursing home or they have to go into a nursing home, you guys probably have heard the spend down and that they have too much money and they don't have enough and they have to get Medicaid. That's what we get our social worker involved with, and so they help make those transitions smooth for patients. And we work the same way in the facility as we would with you guys. We don't take away the care, we're there to accessorize it and just provide additional. So maybe I have a question so far, I don't want to run through everything. You guys still hanging with me? I know it's a lot of stuff and it's not the best conversation, but it's reality. So a patient, can you go back to eligibility? Okay, so for a patient to be on hospice, 2 physicians have to deem them eligible. So it can be their attending physician or their primary care doctor, which usually gives us the order. Then the medical director, once the nurse goes out and does an evaluation and provides the doctor with what she's seeing clinically, they both are in agreement to admit the patient. And it's like when you go to sign for a car or a house, if you ever bought something that requires a lot of contracting, there's a lot of paperwork to that. So when the patient goes on to hospice, they're understanding that they're electing to have comfort care rather than curative care. So what we do is we become the 911. They no longer automatically call 911 and rush to the hospital. But I always tell them you have the right to go. If you feel that your parent needs to have a medical evaluation, they have the right to go. All you do is you revoke your hospice benefit, you go to the hospital, and then when you're done, if you want, you just go back on. You can go on and come off. Did anybody know that? Okay, and another thing is, you don't have to stay on hospice. Just because you sign on, you don't have to stay on until you expire. You can change your mind. Your doctor can call you and say, Jan, I have this new pill that I think would really help you and stop the progression of your disease process. What do you want to do? You have to come off hospice, but yes, you should try it. Everybody deserves a chance to try it. Okay. So common misconceptions are that patient must be in the final stages of dying to be eligible for care. Remember I said most people wait 3 to 5 days before they go on. At that point, sometimes they're not even awake, and so we don't know what their needs are. And that doesn't really give the whole hospice team a lot of time to go in there and wrap their arms around the family to actually provide that additional support. So they don't have to be, we can get involved earlier. Hospice care is just for elderly and cancer patients. And this seems to be a really hard one for people. We have patients that, and I'm sure you see it, they're in their 90s and they're good. Maybe they can't see as well or can't hear as well. But sometimes we'll get calls from people, from family members who are on the fringe, and they might, they're trying to oversee it, but they're working. They might have a service in there helping out as well. And they'll go, can't you put them on hospice? I mean, they are 94. They're old. They're not going to be here forever. they're here now and they're not sick, so they can't go on. So the hospice Medicare benefit pays for only 6 months of care. That's not true. It's the first 6 months is the first certification period. After that, they're recerted every 60 days until they're no longer eligible. If a patient elects hospice, they can no longer see their primary care physician. Not true. They can still see their doctor. They can still even see specialists if it's not for the hospice diagnosis. So what that means is, like, let's say you have a diabetic and that patient comes on because they have kidney failure. And so they see a primary care doctor and they see a kidney specialist. If they elect to go on hospice, they would forego seeing the kidney specialist and they can still see their primary care doctor. A lot of primary care doctors are focused on curative care. They don't get much training for hospice. And they have to say that they have to sign a certification that says the patient could be pass away in 6 months. They always guess wrong. I mean, they notoriously, there's lots of studies where they pick the wrong time. So electing hospice means the patient and family has given up. That's one of the myths, and that's not true. You might read this in the obituaries where it says, she fought a long, hard battle with breast cancer, or he was a warrior in his fight against Parkinson's. That's what we culturally are programmed to believe, that if people are electing hospice, that they're giving up. And it's not about giving up, it's about what do they want? What type of quality do they want? A lot of these people that do that, there comes a point where they spend the majority of their time in and out of doctor's offices and in and out of getting poked and prodded and treated treatment that is making them sicker than they were before they started. So it's all about what does that individual want, and you can't, you have to kind of, only they can make that decision. Sometimes, and we do use certain medications. Morphine, you probably heard they use morphine, and you probably have heard, well, I knew my neighbor was on hospice, and when they went on morphine, then they died. Morphine is only one of the medications that can be used, and it's called a comfort medication for the end of life process. And the reason why we use morphine is because it's very fast acting and it covers more than one symptom, and it doesn't build up into the patient's symptom in systems where they're snowed all the time. So it helps with anxiety, it helps with breathing. It can also help with, just the whole pain along the process. Don't change it. So there's 4 levels of care. One is you have access to 4 levels of care. That's in the home, in the hospital, continuous care, or the third one is where they go to like a facility. We utilize Altman Woodlawn Compassionate Care Unit if we have somebody that just has symptoms. The people that go there are usually coming out of the hospital, they don't have a caregiver, and they're on their way out. Or somebody in the home who we can't manage them in the home, they might need an IV medication. We contract with them and we would send people there. I've been here 3.5 years and we've only sent 1 person that I'm aware of. So most of the care is done in the home and is provided by family or other caregivers. Okay, we talked about that. So you should be at interdisciplinary team, the circle 1. There we go. So patients and family are the heart of the middle. We have volunteers, physicians, spiritual counselors or chaplains, social workers, bereavement counselors, aides, therapists, and then my part says, and you, because you guys play a part of this as well. So if we work together, it's a win-win situation. Where we have those patients that need the additional care that we cannot provide, we're going to call you and say, hey, can you guys help out with this patient? The family cannot do it. It's a win-win situation because what we try to do is keep people at home. What you need is people at home to take care of. So when your patients go to the hospital, then you don't have those hours, right, until they come back. And so if we are able to keep them home and comfortable, it's a win-win for both of our companies. and for us financially, personally as well, fill their pocketbook. So as a caregiver, you guys are in a unique situation. You see the subtle day-to-day changes of a patient's condition. Things that you want to look for when you're in the homes are weight loss, if they stopped eating, are their dentures not fitting anymore, are their clothes not fitting like they used to, are they having difficulty swallowing, are they pocketing their food, or you'll go, you might sit there with them while they eat, and then they have to go to the restroom, or you're going to do the bath. I can think of, I worked in a nursing home and worked in a hospital, and you go to this room and it's like, these two aren't ready, so I'm moving down to the next. This is my whole assignment, right? So you gotta just keep moving. And sometimes they're not ready. Or you might go get them and they put the last box, or the last thing in their mouth, and then you go in and give them a shower, and you notice that they're going, what's in your mouth? Well, that was your breakfast. They are no longer eating like they used to. They're having trouble swallowing. If they're starting to have a lot of ER visits or hospitalizations, there's something else going on there. If they're having shortness of breath, when they're just sitting there doing nothing, or if they're just minimally exerting themselves, then they are also somebody that could benefit from services. Or if the family or the patient just expresses a desire to stop treatment, because they might tell you first, I don't think I want to go to that specialist anymore. I don't think I want to do that anymore. Well, then that's where you can probe into and say, let's talk about that. What do you mean you don't want to? You just don't want to today, or are you tired? You'll hear that a lot. How many people have heard, I'm tired, I'm just tired. What's wrong? I'm just tired. For no reason. They don't do anything, but they're so tired. Or they might be saying, what's next? What am I looking at time-wise? How much time do I have left? So those are all indicators that they might be eligible for hospice. So we have the physician who works with the medical director. We have the nurses, who I told you goes out 2 times a week. We have the hospice aides and the other aides that I think are the most valuable members of the team. You're intimately involved with that patient and family, and you're often the most trusted member on the team. Social worker, a lot of people, this is all part of the team. So social worker, people will say, I don't want a social worker. Social worker is gonna make me move out of my house. But the social worker does so much more than that. They deal with the psychological aspect of somebody having a disease process, maybe isolation, maybe they need outside resources, maybe we need to get somebody like you guys involved. They also can act as a mediator, because they're trained in counseling as well. They can act as a mediator for families. So you guys may have a client where there's a daughter that lives with or near and does the majority of the care, but you have the son who lives out of state who's going to tell everybody else that they're doing everything the wrong way. And so sometimes those situations may butt heads, and you're right there in the middle of it. So that's where something that our social worker can help. I talked about people think they're going to be moving from their home. Then we have their spiritual care coordinators or chaplains. They instill hope into the patients, because regardless of how much time somebody has, there's still a life worth living, and there's still a lot of life in them, and we don't want them to give up, and we don't want them to think that they don't have value to anyone. So we do talk about all that. We also talk about legacy of life. The chaplains don't go in there and say, you need to believe in God and you need to get things right and all that. They talk about, do you have this higher power? And they'll talk religion if they want to, but it's not something that's forced. They can discuss their achievements and regrets if that's something. We have bereavement counselors, and we offer bereavement for 13 months, not just a year. It goes into 13 months. First 2 months after somebody dies, and they get a call, somebody requesting to come out, they don't want any part of it. They're still dealing with it, but we still offer that, and that's why it goes to the 13. And we have done it longer if the patient and family needs, or patient's gone, but the family needs it. Volunteers. These are just a couple things that the volunteers can do. Medicare has a rule that all hospices have to provide 5% of their care by volunteers. So what happens is we have a coordinator who goes out and sits with the family and the patient and says, what do they like? What did they used to do in their life? what kind of hobbies do they like, what kind of music, what would they enjoy doing. They can take people out on outings, they can sit there while a family member or caregiver does other things, but they match them up with somebody who would best fit with the person. We have people that just read for people that have the wrestling glasses. We have people that do puzzles, we have people that go play cards, we have people that play music, and that's all part of the volunteer program. We can provide additional therapy services. A lot of people think, oh, you can't have physical therapy because you're on hospice. You can't have occupational or speech therapists because you're on hospice. We can do some of these for comfort. We don't do it like a patient would do it after they had a knee replacement. So after they have a knee replacement, therapy is pretty harsh. They want to get that bend, they want to get them up, they want to get them moving. This is all for comfort. So hospice will pay for some of these. It's a case-by-case basis. Patients there's certain circumstances where they can still receive dialysis and be on hospice. That's okay. There's a lot of things people don't know. So when you're on hospice, hospice covers all medical equipment that a patient might need. So it's a bed, it's an over-the-bed table, oxygen, wheelchairs, cushions for those wheelchairs, recliners. There's certain chairs, special chairs called Verona chairs. And those are when people don't have any trunk support. I mean, if you ever got somebody up and they're just like, you put them back up and they go right back like that. So there's special chairs for that and they're expensive and hospice covers those. Bedside commodes, shower chairs, lifts, nebulizers, briefs, pads, wipes, and gloves. That is like so expensive for people. We pay for all that. If they have wounds, we pay for the wound supplies and the wound care items. Other essential items to provide proper care, that's just kind of, you might get somebody that says, hey, can you get a specialized fork or spoon, with a bend, and we would help take care of that as well. We cover medications that are related to the terminal diagnosis. So if somebody comes on for heart issues, most of the time a heart issue patient is going to take meds to keep their blood pressure down. They're probably going to be taking water pills or diuretics, Lasix, and it makes them get rid of that extra fluid. We cover all of that. If they are taking those medications as well as diabetic medications and we bring them on because of the heart, we don't cover the diabetic medication. They continue to be on that the way they're paying for it now. Anything that's used for pain or symptom management, when we do add in those comfort meds towards the end, the morphine, maybe there's a medication that's called Lexin that dries up the secretions in their mouth. Ativan is one to reduce the anxiety. So, or any medicine, when I say palliate a related condition, that's all those things I just talked about. So who pays for hospice? So everybody in this room who gets a paycheck pays into 4 buckets. It's the hospital benefit bucket, the hospice benefit bucket, skilled nursing or nursing home bucket, and home care, skilled and home care. Unfortunately, I think non-skilled should be paid, but they don't pay for that, and that's what people struggle with. So all of us pay into that. And by the time you reach 65, you have about $28,000. You cannot dip out of all the buckets at one time. When you dip out of the hospice bucket, what happens is we attach ourselves to the Medicare number. That's why when somebody wants to go to the hospital can't bill because we are billing their Medicare number. Why we have to revoke. So we meet somebody at the hospital, have them sign that. That way, the hospital takes over that billing and the patients will not get a bill, or whatever the hospital then will pay. No one gets a bill for hospice services. Medicare, Medicaid, some 100% Medicare, 100% Medicaid. Some insurance companies have a carve-out plan, but a lot of them have co-pays for the younger people like us. It's horrible what happens to somebody young. I'm older than most of you guys in this room, but it's horrible what happens to people when they get older because of the cost involved. Sometimes a co-pay is as much as you figure you got somebody coming out 5 days a week, and you have to pay a co-pay of $55 every time. That can add up really quickly and completely obliterate that person financially. So, that's tough. HMOs can pay, that's insurance. So why choose us? Will come after comfort measures. One of the things to measure, just gonna talk a little bit about signs and symptoms real quick. What we're here to do is provide comfort, dignity, and support, and compassion at the end of the life. Your role as a caregiver is vital. Your responsibilities are daily hands-on, observing changes of conditions, supporting, and being present with calmness and dignity. One of the things, comfort measures that you can provide for a patient that's passing away, they don't even have to be on hospice, but reposition every 1 to 2 hours to prevent injuries if indicated. Somebody who's obviously on their way out, sometimes it's best just to leave them lay, not put them through that turning. They're going to stop having urine output. They're going to stop having bowel movements as the end comes. Bathing, you just want to use warm water and gentle soap. You want to make sure that you're not using something very fragrant, because sometimes that will affect that person as they're passing as well. Sponge baths are fine, and just the necessity sometimes are all that's indicated. Skincare, you're just going to watch for any redness, tears or open areas. You want to keep the skin clean, dry, and moist. Avoid free friction over bony areas, and sometimes when they stop eating, the hip bones start coming out, their knees, their elbows, or some things that are going to be indicated. You may or may not see modeling on a patient. A lot of times, I know when I was a nurse's aide, the nurses would always come in and flip their covers back and look at their feet, and it's like, well, they're not even modeling. And well, I'm telling you, she's changed. She's not talking to me, she's not opening her eyes. Just because they have modeling doesn't mean they're passing, and just because they don't doesn't mean that they aren't. So always be cognizant of that. Go with your gut and what you know that patient to be like. Mouth care. Sometimes mouth care is very hard to do, especially at the end of life. You may hear that, you've heard that comment, death rattle. They may get that death rattle. And what that is the muscles in the throat, obviously fluid gets stuck there because they're not swallowing. So they feel that secretion. So you just want to use those what do they call that? Toothpicks, swabs. Yeah, thank you. You want to use those as frequently as you can. Sometimes we've all probably had it where we put it in somebody's mouth, they clamp down on it. You're like, oh good, we're gonna swallow, that's fun. But it does happen, and as time goes on, they lose that as well. You also want to look out for signs and symptoms of pain. Just because they don't tell you they're hurting doesn't mean that they're not hurting. So it's going to come out in irritability. It might come out in they're ignoring you. They might play possum in the bed. They might not open their eyes for you or in the chair. They might just, or look at you like you're the dumbest person on earth. Of course that hurt, but they can't tell you where or what helps. So it could be facial, even just facial expressions. So you want to report any of those to your supervisor, or if you're involved with hospice, to your hospice nurse. You want to provide emotional and support. And always remember, I'm sure you've heard this, the hearing's the last to go, so they do hear you. They can hear what you're saying. So you don't, if you know you got a family member who's watching the clock because they got something else to do, and they're like, when's it gonna be? When's she gonna die? And literally you've heard that. Mm-hmm. You want to make sure that you try to protect that patient or client. You want to protect them and try to have those conversations. Sometimes you can't help it. They're who they are. You got to meet people where they're at. Sometimes you got to help them out the door too. And that's physical signs of when they're going to pass. You're going to see that they're sleeping more. They're going to eat and drink less. They're going to go to the bathroom less. They're going to have cold hands and feet. They might not actually also run a fever. A high temperature might be part of it as well, and sweating. Blotchy skin. They may have irregular breathing. They're going to have that death rattle, and then they also can lose control of their urine and stool.
spiritual and emotional signs that you'll see are restlessness, agitation. They might talk to people that aren't there. How many people in here have ever had a client pass away, and they've told you, I saw my husband was here. 2, 3, see, it happens. So they'll be talking about people that, there's nobody back there. We don't know how that happens. Nobody's ever come back and actually said, yeah, I saw that person. So we just kind of got to go with it. Don't tell them that there's nobody here, because in their mind, it's real. Even our dementia patients. So you continue providing that care and notify the nurse. As a caregiver, you guys make a powerful difference, and you help people live on their last days with comfort, dignity, and compassion. So I'm going to skip that. I'm going to say, how can you help? You can make a referral. So if you guys see anybody that you think is starting on decline, I don't have to have an order to talk to them. And I don't hard sell. I go out and I say, what are your goals? What would you like to see happen? Especially those that are tired, that their family's forcing them to do this or that. What do you want to do? Let's have a conversation around that. Anybody can make a referral for hospice. It doesn't have to be a doctor. We do have to have a doctor's order to touch the patient. So we can't take any vitals, we can't look at any wounds, we can't offer medication support without an order. So if you have somebody, you let somebody know, they'll get in touch with me. My cards are back there, and you can get in touch with me, and I can have a conversation on the phone. And I can pretty much tell within a few questions whether they're looking to go that way, or if maybe they need additional support. I like to talk to people in person, because if I'm sitting there, if I walk in and we're sitting there and I have somebody that's sitting here like this, I know which way to take the conversation. They either are not accepting of the diagnosis, or they've had a bad experience. And we only get one shot to do it right. Request a speaker, do that. Anybody, we're welcome. We're always taking volunteers, so anybody who wants to volunteer. And then tell others what you heard about today. You never know who's going to cross your path that you can say, hey, I heard about hospice, and I didn't know that you could go on and off of it. I didn't know that you could, have hospice and have therapy, or whatever it is, and you can share that information with them. And then next. Anybody have any questions? Nobody has questions?
I do. I had a client about 4 or 5 years ago, and they got off hospice because they didn't use their own insurance, their own doctor. So that just recently changed or something?
No, they can use their own doctor. Their doctor may have not wanted to follow them. So what happens a lot of times is, like I talked about earlier, that doctors don't necessarily get a whole lot of training. And they're used to people coming in, and it's like, yeah, you got high blood pressure, here's a pill for this. You come in, what's wrong? You sprained your ankle, oh, here's the x-ray. Oh, you come in, this person, I never want to do that. This person comes in, you don't want to, you're having some difficulty, increased shortness of breath, you don't want to go to the heart doctor anymore, you want a quick dialysis. Okay, you have hospice. They don't want that conversation. They're not trained for that conversation. So a lot of times when we call the doctor and we say, we got an order, maybe the patient's in a nursing home, or even at home, patients call, they would like a hospice evaluation. Will you continue to follow that patient? Which means they're going to be the ones that we call when the patient's short of breath for an oxygen order. They're the ones that we're going to be calling for end-of-life comfort beds. They don't want that. So some do, some don't, depending on how long they've been with the doctor and the doctor. Those doctors that stay with their patients are becoming less and less. Because as you guys probably, your doctor used to go to the hospital. Then they came up with these hospitalists who go in. All they do is manage the patient in the hospital. So the doctors don't go there anymore. So things change, And so they may have elected to not be on hospice because I couldn't see my own doctor, only because the doctor's not going to follow them. It's not because they're on hospice, because they're allowed to see their own doctor. We don't take that away. That's a good question, and a lot of people feel that. Anybody else?
Any other questions? Well, thank you, Jan. That was very insightful.
Sorry, it was a lot. It's a lot. So you can see. You can see why it's a lot. It's a big decision, and there are lots of barriers to getting hospice care. So we follow up the next day. We do the admission, and then we go to the next day too. And then we call them in a week and make sure that they're still, moving with the program.
Just to say, I had hospice for my mom, my dad, and my mother-in-law at one point in time, but my mom was on hospice for almost 7 years.
Wow.
And her doctor is the one that, recommended hospice, even though he told her, you have 5 to 8 years left to live, But he recommended hospice because she had a lung disease and he wanted more care for her. And so just.
And it's paid for. It's paid for.
Right.
The worst thing is that your care is not covered.
Right.
I mean, there are different
I would have
insurances.
never made it with my mom, I would have never made it through everything that she went through without hospice. I mean, they were wonderful, so. And all of you guys, if you see something and you want, you call the office and say, hey, Dan, can you call, so-and-so's daughter and talk about, maybe, with Jan and talk to her, so if you see something, we want you guys to call, Jan or Malia, or, one of your leads and say, let's sit down and talk about this together. I don't want to talk about it in front of the client, but